Welcome to Checking In, a Scottish Rite for Children podcast, where we'll share up-to-date expertise on children's muscles, joints, and bones. Scottish Rite for Children is one of the nation's leading pediatric orthopedic centers. Since 1921, we have been committed to caring for the whole child, mind, body, and spirit. Today, our world-renowned medical staff treats a wide range of pediatric orthopedic conditions, including sports injuries and fractures. Our specialists also excel in the treatment of related arthritic and neurological conditions, as well as learning disorders like dyslexia. Through outstanding care and compassion, Scottish Rite has become a place of hope. We are dedicated to beating the odds in the face of adversity because it's our mission to give children back their childhood. And now, your host, Brandy Schmidt.
Hi, everyone. I'm Brandy Schmidt. I am a clinical program coordinator at the Scottish Rite for Children Orthopedic and Sports Medicine Center in Frisco. Welcome to Checking In. I'll be your host today as we discuss hip injuries in young athletes, treatment options, and ways to prevent those injuries. So let's get started. Today, we are checking in with pediatric orthopedic surgeon and associate medical director of clinical research, Dr. Henry Ellis, and physical therapist and athletic trainer, Jessica Penshorn. Welcome, Dr. Ellis and Jessica. Thanks for joining us today.
Thanks for having us.
Let's get started with some basic information about our pediatric sports medicine practice at Scottish Rite. Dr. Ellis, can you tell us about the program in Frisco?
Sure. We have a comprehensive pediatric sports medicine practice here in Frisco that really takes care of the whole athlete, from injury prevention to the psychological effects associated with the athletes. We like to take care of them when they walk in the door, from any injuries, from basic bumps and bruises to big fractures that may need more serious surgery. We've got a team for almost anything. We really pride ourselves on taking care of kids. Pediatric sports medicine as a specialty has really grown in the last 10 years, and it's because we're seeing so many more kids involved in so many more organized sports. And because of that, it really has fostered a program such as this. We are fortunate enough to have a facility that's dedicated in all aspects to the youth athlete. One of the biggest advantages to this entire facility that we have is the ability to work closely with our therapist. And knowing that these athletes, oftentimes, they need some education, they need some good training, good skills, and working with the healthcare providers that we have here really allow people like me to work with people like Jessica so that we can continue to focus on the athlete from head to toe.
Very good. What are some other specialties or clinicians that are here in the building that you work with athletes?
Well, when we built and developed it, we tried to cover every base. We didn't really want to leave anyone out. So we tried to look at what do athletes need. So not only do they need the doctor, and then they need the therapist, they may need some athletic trainers. I'm a surgeon, so, oftentimes I see kids that may need surgery, but as an orthopedist, I take care of all of injuries. But we're fortunate enough to have sports medicine trained partners that focus on non-surgical problems like concussion and overuse. We like to look at other alternatives other than surgeries for many injuries. So a lot of our non-surgical partners will use the ultrasound for some treatments and consider some injections when needed. We also have state-of-the-art radiology with special x-ray machines that have special low-dose radiation that really allow us to look in more detail with less radiation, so it's really quite neat. We have psychologists that focus on the youth athlete. We have a nutritionist that focus on the youth athlete. I'm sure I'm missing some, but I can't think of any. Jessica, you think of any that we're missing?
We also have down kind of in our same area, we've got the research lab, so the musculoskeletal research lab. So a lot of the kids that are receiving treatment here are also going through video analysis and things like that, so that we can make sure that we have the best standard of practice for these athletes too.
Yeah, I can't believe I didn't mention the Movement Science Lab, because what's so cool about it is, we're really focusing on injury prevention as well. And so I'm sure sometimes as a therapist, you see them after they're injured or when they have a condition you can treat, but the collaboration between you and some of our biomedical engineers to start looking at injury prevention and looking at some of the body movements of the youth athletes with really state-of-the-art cameras that we can really learn how to prevent these injuries as well.
What are some things that are unique about treating young athletes versus adult athletes?
I've been asked this question a lot, and I've always focused my answers around the physical differences, which are really quite clear. And, most youth athletes have open growth plates. And so a lot of the injuries and considerations are different from adults. For example, adult will have tendonitis. Kids oftentimes don't have tendonitis. If they're going to have inflammation due to an overuse, we call it apophysitis. And the reason why it's apophysitis is because it's inflammation or irritation of the growth plate. It's a little bit like the weakest link, right? In an adult, the weakest link is going to be the soft tissue tendon. In a kid, the cartilage around the growth plate is the weakest link, so that's what ends up getting inflamed. And so it's really the growth plates that provide additional diagnoses that you have to consider. And that's how I used to answer it, which is still true. But the more and more I learn about my practice and I evolve, the reason why kids are so much different is because you also got to take care of their parents. And you've got to realize who's goal setting here. And so, when you take care of an adult athlete, you can tell the athlete, what are your goals? And they'll tell you. When you talk to an 11-year-old and you say, what are your goals? They may tell you one goal, but sometimes you don't know if it's their goal or if it's mom's goal or dad's goal or if it's just like their brother's goal. And so there's a little psychology involved, and of knowing about the whole picture in these kids, I think make the specialty a little bit different. So I would say that what makes it different is not only the physical changes in the athlete, but it's also the really looking at the big picture and the psychological differences in a youth athlete because of their influences in school, society, and family that may be able to dictate that. The third reason is athletes change. Their bodies change. A 10-year-old is not going to be the same body as a 13-year-old. And we know that during periods, we call them growth spurts, right? Well, we know that during growth spurts, you have a ton of body changes. Well, guess what? You also have a ton of pain if you maintain the same level of athletics, and you have higher risk of injuries during those periods. So, I think those three areas are really what make this specialty a little bit different. I'm sure it's different for you too in physical therapy when you're taking care of these patients too.
I'd say another thing to add is just the level of education that you have to give. So you've got to educate parents, kind of what you were talking about with the goal setting, with knowing what the patient's goals are versus the parents' goals. But I think the education level for parents as well as for the kids, I think that's another thing that's different too, and kind of making your education or making sure that the kids understand what's going on with them and why we're doing what we're doing is important as well. And I think that's very different from when I was treating adults or with athletic training. If I go into a college or a professional sport, I'm going to be talking to those athletes a little bit differently than I will these pediatric athletes.
Do you find that sometimes you have to talk to the patient at a different time than the parent? Your education's different, but sometimes you kind of want them in two different rooms, so you tell them different things, but it's kind of the same message, but two different ways.
I love the way our clinic is set up because it does allow me to do that. And so I will take the kid back when I meet them for the first time and I do that initial assessment. I will take the kid back and I will have time one-on-one with the kid first to kind of get to know them, to talk to them first. And then I take the child back out to the parent and then we talk with the parent as well. And so then I'll add an extra layer of education for the parent as well. But I think it's really important in this setting to get a little bit of time with just the kid, getting to know them outside of who they are with the parents as well. So
sounds like this might be tip number 1 for parents listening today. Let your child answer the questions, participate in the evaluation.
That's really tip 1, 2, and 3.
Okay, I'm making some notes. All right. Well, let's talk a little bit more about the hip. Dr. Ellis, can you talk to us about the anatomy of the hip or the way the hip works and help us understand what makes it vulnerable to injuries?
Great, yeah. The hip joint is really a tough joint. The joint itself is really deep in the body. So unlike the knee, where you can see swelling, you can see bruising, sometimes in the hip you can't because it's so deep. It's a ball and socket joint so that it has a big range of motion. Your knee is a hinge joint, right? So your knee just bends and flexes. But your hip Actually, it rotates, it bends, it goes up and down and sideways, and it goes all directions, but it's really a ball and has some limitations around it. So the complexity of the hip is because it's a deep structure, and oftentimes it's hard to diagnose what is going on, and a lot of youth can have some hip problems. Now, the hip and the pelvis together in a youth athlete is particularly important because many of the growth plates around the hip joint are really becoming mature and active during their growth spurt. And so when a kid who is involved in high-level organized sports may start to develop some hip problems that maybe weren't there before because some of these growth plates are starting to become more active. The hip joint is becoming larger, both wider and longer, and so it ends up becoming quite a bit of an important structure. What we see is when an athlete hits a growth spurt, their skeleton grows, but their soft tissue and muscles lag behind about 6 to 12 months. So what will happen is you will get taller and you will start developing more velocity because you have a higher body mass, but yet sometimes your muscles and coordination, they don't know how to deal with this new tall, lanky body. And so you're asking your muscles to do things differently, and they're not quite as strong, and they haven't started to hypertrophy, and they haven't started to warm up to this muscle yet. So the hip joint really is in charge of the knee and the ankle, and it really is the halfway point between the back and the knee. And so you could imagine a lot of hip problems that we see, particularly in the growing athlete.
Do you see more hip injuries in girls or boys, or do they present the same?
Oh, that's really a great question. You know, probably see equivalent hip injuries or hip problems. However, I would say that certain sports probably lead towards one gender over another. For example, you know, Jessica and I, we treat a lot of kids who are dancers and gymnasts and cheerleaders because they put a lot of stress on their hips, and it hurts. And oftentimes it's not a structural problem. Oftentimes it may be cartilage, labrum, overuse, something that doesn't need a surgery, but a clear sign that they're doing mechanical changes to their hip joint that's beyond what their body wants to let them do. And so if you think about a dancer, and let's just talk about the kid who is in drill team, and how many high kicks do they do in practice? I mean, I'm not sure, but when I see it at halftime, it's about 30 or 40. And the hip joint is not intended to allow that to happen. So you're putting strain somewhere you're not supposed to. Some bodies can make it. Some bodies are not made to do that. So, you know, what happens is then you have hip pain. And they want to know why. And, you know, sometimes it's just because you're not supposed to do this. But it's hard. And oftentimes that's where Jessica and I working together, because, you know, Jessica has so much influence on trying to help the hip pelvic mechanics to allow for this to work too. But so that's where we see most of our female hip patients. In males, I mostly see hip problems in basketball, soccer, and football, particularly kickers. If you think about it, they use their hip quite a bit too. So it really is sports specific when you look at the gender breakdown.
Very good. Can you tell us some more about some of the conditions that you see here?
Well, if we break it down into hip injury versus hip pain, the most common hip injury is oftentimes a soft tissue injury, you know, like your average groin strain. We've heard it on TV. NFL players have it all the time. That's probably the most common is a soft tissue. Your hip flexors, your groin strain, those are really quite common. There's soft tissue injuries. You know, Jessica and the team downstairs are whizzes at getting those back. And I really think getting to work with your physical therapist early can help decrease the inflammation, increase your muscular healing a lot quicker, increase some oxygenation, blood flow to that area can really help. We sometimes see growth plate injuries as well, where they're actually, you know, some people will see what we call an avulsion fracture or apophyseal avulsion fracture, where it's where the muscle actually pulls a piece of bone off. And that is only an injury that occurs in adolescence. We call it apophyseal avulsion. Most of them do not need surgery, but they do need good rehab and time and motion to get them to heal. Some of the overuse conditions, or what I would call hip pain, there's really three main buckets of hip pain. The first one is just overall inflammation of the growth plate. We call that apophysitis. We see it quite commonly. The second one is, which is what we commonly see in some of our dancers or gymnasts, and we'll call it hip instability. Now, not like a baby hip instability, not like a dislocation from a football player, but little tiny motion in that hip joint from abnormal repetitive use can really cause quite a bit of irritation, inflammation, and chronic pain within the hip. We see that quite often. The last one is hip impingement, and this is really a buzzword right now because we've learned so much about it. We know how to treat it. We call it femoral acetabular impingement. The femur is the ball. The acetabulum is the socket. Sometimes those of us in the industry will call it FAI for short. But what it is, it's just hip impingement. It's where the bony part of the ball pinches on the socket. If you think of a ball and socket joint, well, that ball actually has a lever arm. So if you think about it, when that lever arm hits the side of the socket, it's going to cause pain because that's where the labrum is, and that's where the cartilage is. So not all the time when you have hip instability is a structural problem. Sometimes it can be a dynamic problem that Jessica helps out with. But those are kind of our main buckets of conditions.
We'll be right back after this.
Our team is committed to caring for young athletes even before they may need us. At Scottish Rite for Children, we have a certified sports dietitian who works closely with this population to help them understand the importance of sports health and nutrition and fueling the body to stay healthy and in the game. Learn more and check out our latest resources on our website, scottishriteforchildren.org/nutrition.
We're back to Checking In with Scottish Rite and your host, Brandy Schmidt.
Can you tell us a little bit about the treatment plans you might have and what kinds of considerations you have as you make a plan for a patient with hip pain or a hip injury?
Well, I think the first thing to do is to identify what the problem is. And every condition I treat in the hip does not need a surgery off the bat. It's pretty rare. Whether it's a labral tear or someone told you they need a hip arthroscopy, most condition in kids do not need a surgery off the bat. So number one is we've got to establish what the diagnosis is. Number two is we've got to establish what their activity levels are and how we can modify that to quit putting strain on that hip joint. And then honestly, one of the keys to taking care of any hip patient is having a really good therapy team and being able to talk to them frequently. So that's where Jessica and her team really allow a lot of flowing discussions and opportunity because most of these kids need good conditioning, good therapy. They need to understand what the problem is and really dial back on some of their activities as well.
Well, Jessica, why don't you tell us a little bit about how you'd start out with a patient that's coming to you for hip pain or a hip injury?
So if Dr. Ellis sends me down a hip patient, some type of hip pain, I'll go through a formal assessment, which includes screening that joint and then the joint above and the joint below. I look at things like range of motion deficits. Do they have a difference in range of motion in one direction versus another? With people like our dancers and our drill team, I look at, do they have increased flexibility in one area versus another area? I'm also looking at core strength, core stability, and then hip muscle strength, and do they have any imbalances, right versus left on those? And then, like Dr. Ellis said, throughout the whole treatment, we're in pretty good communication with each other on whether this conservative treatment is working. Also, since I spend a lot more time with patients than Dr. Ellis is able to, sometimes I will get more information out of a patient. Like they may tell Dr. Ellis, no, we're not really doing a whole lot as far as sports go right now, or, oh, we've decreased how many hours we're doing. And then I find out later, that they have not really changed their frequency or their intensity of exercise at all. And maybe that's why they're not getting it better. And so that I can go back to Dr. Ellis and we can kind of talk about changing game plan, maybe adding activity restrictions for a little while just to get them better. And then as we correct some of those muscle imbalances or the weakness or increase flexibility in some area versus another, then we can start adding back in those activities gradually over time.
Dr. Ellis mentioned pelvic mechanics and hip mechanics earlier. What does that mean? How can you help us understand that?
So mechanics would be the system in which the body moves. So the coordination between your muscles, your nerves, your bones, and your pelvis and your hip are very closely integrated. And whether like when you bend over or when you rotate, is a lot of that motion coming more from the lumbar spine or the pelvis versus the hip? Or do you have increased motion in the hip and your pelvis isn't moving very well? When you sit down and then when you stand up, do you get a lot of movement through the hips, or is most of that coming from the lumbar spine or from more the lower extremities, the legs? So it's kind of the system in which the body helps all the bones, the muscles move correctly or initiate movement correctly. And so we sit down with the patient and we look at all of these movements, both their normal functional activities, so they're sitting, they're standing, they're walking, and then also their sport activities to see if there's any abnormality or difference in the way that they're moving versus the way they should be moving, so that we can address those things.
What are some treatment options you offer? Is it exercises, or are there other things that you offer to patients?
So they will go home after an evaluation with a home exercise program to kind of work on hip and also core strengthening. They might have some stretches on there as well. Another thing that we offer in the clinic is dry needling, and I am dry needling certified. So sometimes more of a quick muscle release if we've got some muscle tension or muscle tightness somewhere. Sometimes dry needling can heal that up a little bit quicker than just sending them home with a stretching program, but I will send them home with a stretching program as well. And then sometimes their pain might be initiating from a muscle, so they're getting that referral pain from a certain muscle. So sometimes dry needling a muscle will help with that referral pain into the hip as well. We also have a HydroWorks pool. So sometimes when I'm getting the child back into their activities, we'll do a little bit of running in the pool first before I initiate running on the turf or the track or the treadmill. So those are just some options that I explore with the patient depending on their specific needs.
Very good. So Dr. Ellis, you said most kids don't need surgery, but let's talk a little bit about those that do. So what happens if therapy's not successful or doesn't get the patient to their goals that they're working toward?
I think naturally as a surgeon, sometimes kids don't respond to therapy and that they need a surgery. And they're all really great surgical options. One of the really important considerations is surgery is not always just that quick fix. We know that surgery, whether it's to fix a labrum or to shave bone because you have impingement or to repair a muscle that tore, whatever it ends up being, I really believe that the surgery itself is about 20% of the outcome. The commitment that you need for your body's recuperation, rehabilitation afterwards is really vital. And I find that sometimes the patient really needs to understand that. So I'm a hip arthroscopist, so I have an interest in things that I can fix with a camera and minimal invasive instruments within the hip joint. And but I would tell you that if you're not committed to the rehabilitation after the surgery, the reality is you may get worse. Sometimes I got to tell people surgery will just make you different. The biggest problem with something like hip arthroscopy is if you don't get your hip moving quickly, it has a really high rate of developing scar tissue in the hip joint. And so that's why after a hip arthroscopy, we get them on a bike the very next day. And I tell them, that, part of the success of surgery is getting your hip moving right away. I don't necessarily think that if you fail physical therapy, is it really a failure of treatment? I think some conditions, most conditions, we know this from the literature. Most conditions in the hip, whether it's a labral tear or hip impingement, can be treated with a good physical therapy program. Now, recently, Jessica and a few other colleagues and I were talking about some of these kids that were really frustrated because they came to my office and they said, well, I was told I had a labral tear, and I was told I had hip impingement, and I was told I need surgery, and you're the person to do it, so where do I sign on the dotted line? And I said, wait a second. Let's talk about this a little bit. And we dial it back, and I said, and I go through my evaluation, examination, try to determine the right diagnosis, and I said, you know what, you really need to go see therapy. And they said, well, if I do therapy for 8 weeks, will you then do my surgery? And when you hear that, you always know it's a bit of a red flag. I mean, you have to buy in. I mean, we know clear as crystal that if you protect your body, you take away the aggravating activity, you do proper hip mechanics, let's just say you work with Jessica, we know that majority, I'm talking 80% get better. That's not 90%, but it's 80% get better. So it's worth it. It's worth it. Now that 20%, then you have that talk, right? And then you have a discussion. But many times I think it's the buy-in, Jessica, that sometimes is the hardest part for them, because to convince a parent that they need to take some time away from their sports is really hard if I send them to therapy. I can only imagine the struggles you have when they have a problem that could really be treated if they just change their activity and they modify some of the pelvic mechanics. But when they have surgery, they mentally, I just had surgery, so clearly I can't do my sports for 3 months. Well, if you didn't do your sports for 3 months and you rehab your body, you may have had the same outcome. We really try hard, working together with Jessica and our everything else, to really try hard to really be sure that surgery is needed as a last resort.
Jessica, do you have some thoughts on which kids are more successful in that phase? Are there some character traits or personality types that do really well with you in that rehab?
Well, like Dr. Ellis was talking about with the buy-in, I do get patients at times where they come downstairs and they say, like, hey, I have a labral tear. I don't understand why I'm doing PT and why I'm not getting surgery. And I think up front, and then later on when we get to that point where maybe they do need surgery and they still have pain with certain activities, I tell them, hey, it doesn't matter if you have conservative treatment first. It's going to be better outcomes after surgery in the long run if you do end up needing surgery, because if your hip moves better and if your muscles are stronger before you go into surgery, you're going to have much better outcomes and you might have a faster recovery after surgery. And so sometimes with the more frustrated parents and patients that come down for their evaluation after getting a labral tear diagnosis, sometimes telling them that helps with the buy-in beforehand. And then sometimes some of those patients even do well in PT and don't end up needing surgery afterwards. But I think, like Dr. Ellis said, that the buy-in is very important in the beginning, and helping them understand why they're doing PT first, and that it's not going to be a waste of their time not to have the surgery right away. I think with a lot of kids, the ones that do better in PT are the ones that are more compliant with their home exercise programs, and they're compliant with activity restrictions. And then also the ones where parents buy in as well. I think parents have a huge influence over their kids and what their kids do. And I think if parents buy in as well and kind of help encourage their kids along the process, I think they do better in PT as well.
Can I comment on the labral tear? Right now, the perception is if you have a labral tear, it needs to be fixed. And that's really a misconception. I mean, it is really not true. For those that are listening that may have a kid with hip pain, or maybe they're struggling with an MRI report that says they have a labral tear, or maybe you've had one in the past. And some labral tears do really well with surgery, so I don't want to discount it. But different from a mid-20-year-old or 30-year-old or 40-year-old is very different from a kid. A 14, 15-year-old that will have to take a year off of their sports for recovery, or a half a year off for their recovery. But so here's the deal with labral tears. I was involved in a study when we were in Colorado where they took healthy young adults and they did an MRI and they blinded the radiologist as to who the patients were. But these were all healthy and had no complaints of hip pain. 68% of the 68% of the MRIs were red to have labral tears. Yet these active young adults had no symptoms of hip pain. In orthopedics, in my profession, we oftentimes think this is very synonymous with the herniated disc in the back. Some herniated discs cause a lot of pain. But when you look at everyone walking the streets of Texas, more than half of us have herniated discs. So which ones cause pain, which ones don't? We don't know that. That's number one. Number two is a labral tear is usually a cause and effect. It is the effect of a situation. It is torn usually because the hip is unstable or it's impinging or it's pinching, right? Most of the pinching we see in adolescence is because of the dynamic motion in the hip that Jessica's talking about, where if you can fix some of the way your hip moves or your pelvis moves, you will offload that labrum and improve. You also got to decrease what they're doing. Now, some labral tears are because of structural abnormality. They have too much bone in their hip, and I actually have to go in there and shave it to then go fix the labrum. Now, the third thing about a labral tear is a labral tear that is read on an MRI report may be 2 millimeters. And to do surgery on this, I've got to actually make an incision through your capsule about 3 centimeters long. I have to detach at least 1 centimeter or more of your labrum to fix a small area of a labral tear, when oftentimes I really think that it's the effect, and if you take care of the cause, it'll really improve that labral tear itself without needing surgery. But I can't figure out why parents and families believe that if you have a tear, it needs to be fixed. It's never been in the orthopedic literature. I just don't know why that perception exists.
You're listening to Checking In, a Scottish Rite for Children podcast.
Our team enjoys hearing about our current and former patient success stories. To tell us about your MVP, visit our website, scottishriteforchildren.org/sports.
Welcome back to Checking In, a Scottish Rite for Children podcast.
Let's talk a little bit about preventing hip injuries. I loved hearing you say that you really don't want to see athletes come out of their sport for a year if they don't have to. So what if we can do things to keep them in their sport and not get the injuries in the first place?
So we are learning every day about injury prevention all the time. And if you are a parent of a youth athlete and you do not know injury prevention for ACL or a throwing arm, we need to look that up and give you that information. It is now well studied, well understood. Medical science highly endorses injury prevention programs for ACL as well as the throwing arm. Now, hip injury prevention is new. It's a new topic, it's hot, and we're learning about it right now. One of the key concepts to the hip, like many other joints, is we see a lot of patients that start developing hip pain during their growth spurt. And what happens is you, when you are young, before you hit puberty, your body allows you to do a lot to it. And even doing a 2-hour soccer practice, let's say, or 2-hour cheer practice, it puts a lot of strain on your body. And when we use the word strain, what it does is sometimes it's micro tearing of the little tiny ligaments, right? Well, when you're before puberty, those heal right away, right? You have this great ability to regenerate and remodel. But once you hit puberty, it all changes. And so your body changes and you have to take care of it. So you have to get an off season. You have to prepare your body. So, you'll talk to some kid who says they've been having hip pain for 6 months and they recently hit a growth spurt. And I said, well, have you done anything to condition your body? How good are you with stretching? Or do you just go out and play volleyball for 14 hours a day? And they said, well, I've just been playing volleyball for 14 hours a day. It's never bothered me before. And now you're 6'2" and, you're a high-level volleyball player, but you're not doing the proper mechanics and conditioning for your body as well. Now, the hip goes through a tremendous amount of remodeling, surprisingly so, almost more than other joints during your growth spurt. And so this is where we're really learning a lot about injury prevention. So we really think that the growth plate around the hip joint, as well as the development of the pelvis, can really be affected with high level of sports during your growth spurt. So we really just, when your kid starts to go through puberty, is a time to reassess how much activity he's in or she, and what are you doing to take care of the body while you want to maintain a high level of sports. So as soon as they start hitting some signs of early puberty is the right time to start thinking about that.
Jessica, how about you? Are there some exercises or activities that athletes can do to take better care of their hips?
I think, like I talked about a little bit earlier, I think core stability is really important for these kids who have just hit their growth spurt. We talked about how they have a lot more bone and they've gotten a lot more height, and their muscle strength has not caught up yet. So a proper core stability program, and also just increasing hip muscle strength, and then a proper just general stretching program would also be very helpful. So what I mean by core strengthening, I'm not talking about those six-pack abs that all of my patients come in and they're real excited that they're going to work with me and now they're going to have 6 or 8-pack abs. It's more those smaller muscles, those stability muscles that we need to strengthen to help with that hip motion. That proximal stability or stability through those core muscles help facilitate distal mobility. So the stronger that your core, your trunk muscles are, the better that your legs can move during sports. So I think it's really important to do that. And there is also an importance in both static stability and also dynamic stability. So there's exercises that work on static stability, such as your planks and your side planks and your planks with leg lifts. And then our dynamic stability would be more like your glute bridges and dead bugs. And I think both of those have their place in an injury prevention program. They both help with more of that dynamic stability. So allowing your body to have good balance when you're moving, so that you're not just flopping all over the place when you're trying to play your sport. And then also doing some hip strengthening exercises like your clamshells, your side leg raises, things like that are also really important to just kind of keep those hip muscles strong as you're growing.
I recognize a lot of those, but dead bug is a new one to me. Is there really a dead bug exercise?
There sure is.
What is that?
So you lay on your back. You're going to put your arms kind of at a 90-degree angle with your elbows out straight. Your legs will be at a 90-90 position. So your hips are going to be bent and your knees are going to be bent. And then we'll start normally with just leg movement, because especially during puberty, a lot of kids have trouble with coordinating arm and leg movement together. So we start with just arms or just legs and kind of holding those stomach muscles nice and tight, keeping that back nice and flat and pressed into the floor. And then we'll do opposite arm, opposite leg movements at the same time.
You know, these hip patients, I would love your thoughts. I perceive, seeing back pain and knee pain and shoulder pain and elbow pain and neck pain and ankle pain and foot pain. Sometimes I feel like these hip pain patients almost take a more of an emotional toll on their body. And I'd love your thoughts on if you agree. Is there just a little bit more of some concerns when they have a lot of hip pain, or is it just my perception because I see a lot of hip pain?
What do you mean by emotional toll?
Well, I just find that these are the ones that have more chronic pain symptoms. A little bit more in my practice on the ones that seem to be in so much pain they have to come home from school. Those that want to stay home from school longer. Sometimes you say hip pain where they can't get out of bed. But, I see back pain and knee pain, but I feel like these hip pain patients, it's like they take over their body sometimes, but yet oftentimes it's not anything on x-ray and MRI. It's not a structural problem, but it's more of this pain that really consumes them emotionally to a point where I worry so much about mental health and getting psychology involved.
Yeah, I would agree. I think there is a huge emotional component to these hip problems. And I don't know if it's because the hip is involved in so many activities, not just sports related, but also just in your daily activities. You're bending your hip over and over when you're sitting down in a chair and standing back up again. So your hip joint is involved in a lot of activities. But I do think that there's a really big emotional component to it. And a lot of these kids also do end up needing maybe a psychology evaluation, and they end up needing some help with learning how to deal with pain. They need help with relaxation, breathing techniques during PT. So I work very closely with our sports psychologist with some of these hip patients. She will see them and then she'll help me with certain techniques that I can implement into their program to kind of help with that pain aspect of things, because it's not related to necessarily their joint mobility or their muscle imbalances or things like that. And then I also think that a lot of these patients do really well with dry needling. And I don't know if it's just the hands-on, the fact that you're doing something to their body or to their joint, but a lot of them get a lot of really good pain relief with dry needling. It kind of releases endorphins, helps them feel good, and also relaxes whatever tight muscles or tension that they've been kind of building up in that hip.
So I'm just gonna ask the question because I don't know if anyone really wants to know it, but what in the world? Why does dry needling work? What do you do? I mean, what if you don't like needles?
So we do a lot of education beforehand because a lot of my kids do not like needles. I also bring parents back the first time too if the kid needs a little extra emotional support. But it works in that you stick these small acupuncture needles into a muscle that has a lot of tension, maybe into a muscle trigger point, and it causes that muscle to contract and tighten up and then relax. And so you kind of get rid of some of these muscle trigger points. And kind of what I was talking about earlier with like the referral pain, it might be referring from a tight muscle. And so by releasing that tight muscle, you also get rid of that referral pain as well.
So I had surgery about 5 years ago on my shoulder, and I thought, boy, every surgeon should have surgery so you know what it's like to be on every side. So have you had dry needling? Or
Yes.
Have you practiced on yourself? Okay, good.
Yes. So
Good.
To get certified, we had to get every single body part dry needled and practiced on each other, which some were not very pleasant at all, but helped after the fact.
So you can say you know what it feels like.
Yes, I do. I know it feels like head to toe, even facial muscles. I know it.
Well, before we wrap up today, let's talk a little bit about how we get these athletes back to their sport. So what kind of decision-making process do you have when an athlete's been treated either with therapy or therapy and surgery to get them back into their sport? I heard you say rest is really important, but there's got to be an end to rest sometime. So what's the plan there?
Most important strategy to return to play is to set up expectations from the get-go. And, I love Jessica's thoughts on this, but we oftentimes treat different types of athletes different ways. And to try to, when you meet someone for the first time and you're trying to get a feel for, is this an elite collegiate athlete? Or is this I shoot hoops with my buddies in the backyard athlete? And so you try to phrase that in a way where you don't offend them, but you're really trying to see kind of what their goals are, because that helps us kind of guide what our return to play criteria are going to be. And really, I love treating all athletes. It doesn't just have to be the elite or the recreational athlete, but guiding that return to play decision, it's so important to know what their goals are from the get-go. And so what do we have to get to? What do we have to achieve? And how much time do we have to achieve it? Some of the more challenging conversations is when you have an athlete that says, Doc, listen, I need to play in 5 months because otherwise I don't get a scholarship. And the parents are like, well, we're not those kind of parents, but a scholarship's sometimes it's $500,000. But I mean, it's a big deal. It's an opportunity for a kid to go to college that may not have an opportunity to. It's a huge investment, and we don't want to give up our bodies to do it. But hey, if we can fast track it this way and make some things to maybe make it a little bit better, those are the things we need to know from the front end. So, number one, getting to know about it from the front end. Number two, become best friends with your therapist. Your therapist, my therapist, Jessica, is going to tell me more about when an athlete is ready. As a surgeon, I have an opportunity to look at some patients. I wish I could see them for 30 minutes or an hour, but we just don't. I get a 15-minute snapshot to look at swelling, range of motion, pain, complaints, and then that's it. But really, that doesn't mean they're ready. What means they're ready is when they're fully physically rehabbed. I oftentimes suggest that it needs to be 90% as good as the other side, but for some elite athletes, you want that to be 100%. You don't want asymmetry is not good for elite athletes. And so the reality is, from a surgeon perspective, I want to know, is what we're treating healed or healing? And that is variable depending on the pathology itself. A lot of surgeries can heal within 3 months, but it doesn't take their body to rehab for another 3 months, so 6 months total. But I really think return to play decisions have to be done in conjunction with your physical therapist or an athletic trainer, or really all three of you.
Yeah, I would agree with that. I think, like Dr. Ellis said, I think finding out goals and setting expectations for timeline are really good initially. As far as the things that I look for when I'm talking about returning a kid to sport, I'm looking at basic range of motion. Is it equal to the other side? Is it within normal limits? I want the strength of that affected side to be at least 90, but preferably above 90% of the unaffected side. I'm looking at single leg stability. So do they have good static balance? Can they stand on one foot well? Do they have good dynamic balance? Can they squat on one leg without losing their balance, without letting their knee cave in, those kind of things. We also do some functional testing. So I might do a Y balance test, which kind of shows me if they can squat and reach 3 different directions on each leg, and if they're within 4 centimeter difference of right versus left. So it kind of shows me if there are any functional muscle imbalances left over if they don't pass this test. Once I kind of go through more of the static and the squatting, then I'll go into impact activities. So I'll look at their running mechanics. Do their running mechanics look good, or are there still some abnormalities with that? I test double leg and single leg loading. So any hopping and landing mechanics, do they land well? And I might look at single leg power with a hop test as well. If all of those things are a check mark, then they get returned or released back to their sport.
Very good. You guys, I really enjoyed our conversation today, and I love watching y'all work. I know that the kids that work with you can tell that you talk and that you work together very well, and that our team is very collaborative. And I think that this was a fun conversation, and I hope others learned a lot from you today. So thanks for being here.
Thank you.
Thanks. I really appreciate it. I would also just comment that a lot of the exercises that Jessica talks about, I know there's resources online for them in which she's demonstrated them herself. So I would really encourage you guys to consider watching them, because I've implemented a lot of them with some of my own athletes in my own household.
To learn more information about any of the topics discussed on today's podcast, check out our website at scottishriteforchildren.org. And be sure to subscribe to Checking In with Scottish Rite. This podcast is a production of Scottish Rite for Children. The host for this episode is Brandy Schmidt. Our producer is Maggie Dingwell. Our editor is Amy Krajewski. Our assistant editor and recording engineer is Stuart Allman. Our theme music was composed by Scott Holmes, and his music can be found at scottholmesmusic.com. Thanks for listening, and we look forward to seeing you at our next episode.